There are lots of different presentations for kidney stone disease. One of the ones that's most interesting at the moment is painless. So people have, because of the number of imaging people are having done for other conditions, often there's an incidental finding of a kidney stone. So you may not know and it's picked up on a scan. The classic presentation of a kidney stone is the dreadful ureteric colic pain. This is one of the worst pains people can experience. Ladies who've had babies and who've had a stone would definitely rather pass a baby than a stone. So it is certainly equivalent to the severity of labour. Disabling, scary, horrible pain. So there's the acute presentation when it's awful, there's the incidental finding, and then some people know they've got a stone because they have this long-term grumbling pain in the loin being the back between the chest and the back of the pelvis. The beauty about looking after people with stone disease, they can impact on you from nothing, as I've said, being an incidental finding, causing no pain, to actually being life-threatening. When they're life-threatening at the other extreme, this is when they're associated with superadded infection, with obstruction. In that situation, there's a risk of septicemia. But the majority of people, the risk is slow damage to the kidney and recurrent infections. There's a huge variety of treatment options for patients. If you present with a ureteric stone, so you present with this ghastly pain, in the majority of people, they will pass the stone spontaneously. So most people with a small stone, 80 to 90% chance of clearing it spontaneously within 4 to 6 weeks. If, however, that stone doesn't pass, or it's of a size that we don't think it's going to pass, we would then consider intervention. And our interventions range from using extraordinary technology called, bear with me, extracorporeal shockwave lithotripsy, or ESWL, all the way through to open surgery where we'd actually have to perform surgery to remove the stone, big surgery. The majority of our interventions, however, are endoscopic, and what we mean by that is using the natural conduits of the body. So we go through the bladder and up the ureter, and we treat most of our stones that way with a laser. The lithotripsy is an outpatient procedure where we use shockwaves from outside the body focused in to smash the stones to pieces with the idea that the stones will pass spontaneously. And then we have the ureteroscopy, which is the one through the normal conduits through to an operation through the back with a telescope all the way to open surgery. Interestingly, most recently, there's some evidence coming in for the role of tablets and what's known as chemodissolution therapy, where we can actually use medication to dissolve stones. This is really only in 1 or 2 types of uncommon stones, but with the rise in obesity, there's a higher rate of uric acid stones. And uric acid stones grow in acidic urine. So if we can alkalinize the patient's urine with medication, we can actually treat the stone risk and actually treat a stone. In the majority of patients, we don't know the cause. And so in medicine, when we don't know the cause of something, we call it idiopathic. And the commonest type of cause for stone disease is idiopathic, we don't know. In some people, we've already talked about metabolic syndrome. So metabolic syndrome can be a cause. There's some very rare inherited conditions such as cystinuria, where you can have an abnormality of your transport mechanism within the kidney that increase your risk. There's some uncommon drugs that can increase your risk of stone disease. Some of the antiretrovirals used for HIV disease and some of the anti-epileptic therapy can cause stone disease as well. But the majority of patients, even in 2018, we don't know the cause. Other causes of stone disease include, within the idiopathic group, there's a whole area of interest in diet and fluids. And so if one were to look at a group of, say, 100 men who form a stone versus 100 men who don't form stones, the commonest difference between them is those who form stones produce about half as much urine as those who don't form stones. In other words, concentrated urine seems to be a predisposing factor. Inevitably, the patients always ask about how much diet influences stone disease risk. And we have to be a little sensible about this. Clearly, there are some patients who have a very high oxalate intake. So if they're eating large amounts of spinach, bindi, strawberries, coffee, chocolate, for example, that can increase your risk of stone disease. There are also some people, there was a lot of talk in the 70s about calcium, and understandably most stones are made of calcium, that it was thought that reducing calcium can actually reduce your risk of stone disease. But in fact, it's subsequently been shown that reducing calcium too much can increase your stone disease for complex reasons. So the dietary argument is quite difficult to establish. It's a bit of yin and yang, and we normally talk about the common sense diet. And within the common sense diet, you reduce your protein intake to a mild degree, you don't add salt to your food, and you hydrate. Given that the majority of people, we don't establish a cause, and we are what we're made of what we eat, there's lots of evidence that modifying diet to some degree can have a good impact on reducing your risk. Probably the most important thing is rehydration or hydration. And what do we mean by that? Well, if you read Cosmopolitan, Vogue, it'll all talk about 3 litres a day. Actually, the evidence for that being good for your health generally is poor, but for stone disease, it's really good. I'm not so much interested in what people drink and how much they drink. I'm really interested in the regular production of dilute urine. That reduces the risk of the chemicals crystallizing in your urine. And how can you tell that? Well, the way to tell is the color of the urine, and you can titrate the amount to drink by the color of your urine. And the beauty of that is that you don't go for 3 litres if you're exercising all the time. You may need more than 3 litres. Equally, if you're sedentary, you may need less than 3 litres. So as long as you keep an eye on your urine and it's a color of probably a light Pinot Grigio or a Champagne, compared to Lucozade, you're doing well. If it looks dark, drink some more and get it nice and dilute. So hydration is probably the most important factor. As far as diet, we tend to say for the average patient, a common sense diet. So that's, you can cook with salt, but don't add it to your food. Reduce the amount of meat you eat to perhaps 5 servings a week. Modify high oxalate containing food intake. So those are the chocolate, the bindi, nuts, spinach, coffee, tea, anything really that's dark is usually oxalate containing. And I wouldn't want you to give it up completely. That'll increase your stone risk, but just modify. I have patients certain ladies in Wimbledon who will eat spinach 3 times a day. That would increase your risk, but if you were to take it every second day, that would reduce your risk.